of being part of our wisdom community. So if you think of questions, feel free to ask those throughout this time. That is the whole goal of today, is to be able to hear from you. We do have some questions teed up to help start the conversation, but really do want to hear from you and hear what your questions are. It could be about the study or about, breast imaging and things that you've heard in the news or from your doctor. So think of those questions. And when we get started, we'll start off with a couple questions to get us going, and then we'll ask for your questions as well. So thanks everyone for being here. We'll start in a couple of minutes. Joined, we're just giving it a couple more minutes for others to join us, and if you can introduce yourself in the chat. It's great to see lots of familiar names and also some new ones. I see we've got people from New York, Colorado, Oklahoma, San Francisco, Oregon, or no, just below Oregon. So yeah, excellent. And just while we're waiting for it to start, feel free to share not only the wisdom study to participate, but also these forums with others in your community, others in your circles that you think would be interested in joining. We do host these every month on the last Monday of the month, unless there's a holiday. So these are available each month and also recorded and put on our YouTube channel for those who aren't able to join live. All right. So with that, I think we can get started. So welcome everyone. This is our June Community Forum, June of 2025. As I just mentioned,
how did that happen?
I know. We host these meetings the last Monday of every month, and have been doing so for the past few years, really with the goal of trying to bring different topics around breast health, breast screening, and prevention out to the community, but also importantly to learn from you and to learn what questions you have, what topics you'd like to learn about, and so that we can be collaborative in our approach to improve breast cancer screening and prevention for everyone. Today's session is slightly different than past sessions in that we really want to have an open forum and hear your questions. We have some questions teed up, but for the most part, we would love to hear what questions you have, and we can try and group them together by topic so that we can cover several of them during the course of the next hour. So please do think of those questions. You can ask them in the chat. And if there's something that's a live question that you want to ask, feel free to unmute yourself. But for most of the time, if you're not speaking, please just remember to keep muted. The meeting is recorded, so we can share on our YouTube channel after the fact. And we will have a short survey at the very end. And we'd love to hear your feedback and get input on future topics as well. So again, our mission in hosting these forums is really to move forward together toward equity and better outcomes for all. And in particular for breast cancer, our topics have gone into other aspects, but health is health and all parts are integrated. So really we've had topics that are non-specifically on breast cancer as well. So you can see all of the different topics we've discussed in the past. And again, these are all on our YouTube channel. But today we will be opening the floor for your questions. We have Dr. Laura Esserman, who is the overall principal investigator for the Wisdom Study, as well as the director for the UCSF Breast Care Center, and also leads several other large trials, including I-SPY and RECAST. And she is the leader and brains behind all things wisdom. And we have other members of our team who are also on who can help to answer other logistical questions too, should they come up. So with that, we have a couple of questions just again to tee up the conversation, and then would love to see your questions in the chat, and also you can ask them live. So the first question is, why do we need a study like Wisdom, and how is it different than a risk assessment I could get from my own doctor?
So I think the answer today is different from the answer that we would have given when we first started Wisdom. I think people are very interested in risk-based screening now, whereas when we first proposed it back in 2013, 2012, this was not, I mean, or actually when we started the Athena Breast Health Network around 2010, we, started to think, wow, like, why, if we increasingly think that breast cancer is many diseases and that people have different risk factors, um, uh, why are we screening everybody the same? And that really is sort of what, that's really sort of what got us down the pike, sort of thinking, oh, well, maybe we should be looking differently. Maybe we should be doing what the cardiologists do, which is they're starting with risk assessment and then trying to figure out how do we reduce the chance of heart disease. And, that they, um, they went for, when I first started practice, by far the biggest risk for all women was dying of heart disease. But with a number of interventions, diet, exercise, lowering blood pressure, lowering weight, lowering cholesterol, the risk of dying of heart disease has become equal to your risk of dying of cancer. And so I sort of figured, why aren't we doing something like that? And they all started with this big study called the Framingham study. And it's not that we don't have risk models. We have them, but they weren't done as a routine, even though people could plug in and do them. Primary care physicians weren't really interested in them. It's still not done in a very systematic way. And it turns out that they're different risk models. Like if you use the Tyrer-Cuzick risk model, it really way overestimates family history, especially if you're looking at gene testing. So they're not all the same. And of course, all the guidelines are different. So our whole idea was to say, well, how could we start with risk assessment? And then how could we then use that to start thinking about, well, who might benefit from, a prevention approach to lower their risk? And how can we use that information to determine who should get screened, who needs more and who needs less, and who could probably do with a whole lot less, because screening isn't, you know, and that there are problems with screening. Screening finds a lot of stuff that may or may not be that. They can find shoplifter cancers that are just sitting there. And they often miss the really fast growing cancers. So how do we make screening better? That was really the genesis for that. And since that time, there've been a whole bunch more, there's been a lot more work and a lot more interest uh, in risk-based screening and this whole idea. But I think the difference between what we're doing in Wisdom is that we're trying to do it in a way that we're evaluating it. Instead of just doing it and just saying, okay, yeah, it's good. I mean, how do we know it's good? Are we solving the problems or are we not? That there has to be an engine for constantly learning and improving what we are doing. We've learned a lot. We've learned a lot that, yes, we can deploy genetic testing to the population. It can be done. We can look at a polygenic risk score, right? The PRS score, and we can use that to upgrade or downgrade your risk based on the standard models. And there are new tools coming up, mammographic AI. There's all kinds of new things that are coming up. So, but who's evaluating it, and how, instead of just doing it, how do we have a study that's always in the background looking to say, are we doing the best we can? Where are we doing well? Where are we falling short? And how do we keep improving? And, it's just okay, everyone says, okay, screen differently because you have dense breast tissue. Now, everyone thinks that doing screening ultrasound is the right best test. Well, actually, it is not. If you really have high risk, you need some kind of contrast-based test like MRI or contrast-enhanced mammography. There was a study that just came out of the UK that really showed very, very clearly ultrasound is not that sensitive. Not surprising, because if you have dense breast tissue, you need a tool that's going to look at something that's not density to find hidden cancers, and mammograms and ultrasounds are hampered by very dense breast tissue. But if you look at contrast enhancement, that's vascularity, how the blood supply of tumors, that's going to show you something different. So again, that's it. And like the new tools of automating density, these are the things that are going to really help. But each new thing has to be added and looked at and integrated into the model so we can figure out what's the best way to do it and give women the information that they need. There's
And and Laura, as a follow-on, yeah, as a follow-on to that, Stacy asked, which I think you just answered, what is wisdom learning 10 years later, and will risk-based assessment embrace a protocol and be included in routine breast health?
Well, we certainly hope so. Next week, we're going to hopefully get to see our first glimpse of the Wisdom 1.0 results. So, but like one of the things that we learned was that 40% of people who have, that of the people who inherit a mutation that really puts them at risk, like BRCA1, BRCA2, PALB2, don't have family history. So family history isn't necessarily the best way to figure that out. That's why we lowered the screening age to 30, so, and, I think it really depends on what our results show. We're hoping that it'll show that by using this risk-based approach, you're not going to be at higher risk for missing consequential cancers, like more locally advanced cancers, and that it's acceptable to women. We already know that more people prefer this risk-based approach, so we know that. Does it reduce the number of overall biopsies and things that people don't need? Don't know the answer to that yet. And, does it really help us improve uptake of prevention? We know some of that is true. We went from like 5% to 12%. There were about 33% of people who were interested, but we couldn't get to the primary care physician. So, and we also saw a differential on whether you were Black or white or Hispanic about how interested you were in prevention. So we've got lots of work to do, if that makes sense.
And I think one other piece just to highlight is that, what's different about wisdom than what you can ask your doctor for. You just mentioned it, but getting genetic testing for breast cancer is not routine unless you have a strong family history. And so, like you just mentioned, those women who didn't participate in wisdom wouldn't have ever gotten a genetic test through their physician because they didn't meet the family history criteria.
Right.
I think importantly, too, you mentioned the polygenic risk score, which, just as a little background, is also not something that's routinely given back when you do get a genetic test. It's becoming more frequent, but there's still sort of a black box of where that's coming from with other companies. But it is something new that we give back, a polygenic risk score, which is measuring some of the smaller changes in your DNA that, taken one by one, don't really mean much, but when you put them together into a polygenic risk score, can increase or decrease your risk.
Right. And it turns out that there's like the 313. There's 313 of these that when you put them together, it's a predictor of risk, but it predicts your risk of getting hormone positive cancer. That's actually a good thing, because if we know you're at risk for getting hormone positive cancer, then it makes a whole lot of sense to want to suggest something that might reduce your risk of getting hormone positive breast cancer. That might be the reason to take baby tamoxifen, for example, or not to take estrogen plus progesterone. I mean, these are the kinds of things that we want to really make sure that people get back, if that makes sense. And there is actually a set of SNPs that can predict risk in African American women. We are actually interested also in implementing a new tool that can help predict the risk of fast-growing tumors, like hormone-negative tumors, where we don't necessarily have good prevention interventions yet. But we know one thing for fast-growing tumors, that you need to be screened more frequently. That's a group of people, probably, that we should be screening every 6 months. Like if you're BRCA1, that's what we do. Or if you're PALB2 or BRCA2, that we screen every 6 months. Mammograms alternating with MRIs, and maybe that should be MRIs alternating with contrast-enhanced mammography. So these are the kinds of things that we're trying to do. More for the people that need it, less for the people that don't, and trying to tailor that and to keep looking at what we are doing and continue to refine it. So now we're really after, can we improve our risk predictors so we can start figuring out who's at risk for what type of cancer?
And somewhat of a good segue, some other questions we've gotten are around what we're calling now the current version of Wisdom, or Wisdom 2.0. As Laura mentioned, we'll be looking at the data for Wisdom 1.0 next week. And that was the preference tolerant randomized trial that went on from 2016 through 2023. And that closed to enrollment in 2023. And then we reopened enrollment to Wisdom 2.0 in June of 2023. So just about 2 years ago.
And we can say that actually in the 2 years that we've had that open, we've enrolled almost as many women as we did for all of Wisdom 1.0.
Yes, we've had wonderful enrollment and huge interest. And I think, as you mentioned, that's sort of a sign of the times of how far along we've come with just the idea of personalized breast cancer risk assessment, screening, and prevention, where it's not so foreign of a concept.
Right.
Um,
And
but
what's
for
different, so again, we can screen women starting as young as 30 because they're just getting that genetic test. We want to find there's not only 2 to 3% of the population has these inherited breast cancer risk, or probably one or 2% of the population has an extremely high PRS or polygenic risk, many genic genes risk. But for those 3 or 4% of people, we can do a whole lot more, and we should. And we can leave everybody else alone for a while. So we want to make sure that we're getting the people at the highest risk when they are more at risk to get those bad cancers. So the reason you need to retake the test, I wish you didn't, but we picked out specific SNPs, and we didn't, what we really want is the million SNPs that we can look at, and we need it as a platform because all of these tests are continuing to evolve. And so what you want is the platform upon which you can add in the new risk signatures for PRS. And it looks like going forward, probably the most powerful predictors of risk will be whether or not you've inherited a specific error in a gene that puts you at high risk for breast cancer, what your polygenic risk score is, and the probably mammographic density, the automated version that might be able to find the 10% of people. Not that, now if you say, oh, do I have dense breast tissue? About 50% of the population have dense breast tissue. But based on mammographic AI, there's probably only 10% of people who are truly at risk. So that's going to be, I think, a huge benefit. But we've got to figure out, how to organize it, how to implement it, how to make sure that we get that into the routine of testing. So we're trying to be in that front edge of how to integrate all of the pieces. Do you need both pieces? Do you just need one? Can you or how do you best do that? So that's what we're trying to keep working on. We're really in the mode of trying to figure out, how do I improve the chance of predicting what type of cancer you're at risk for? And you do need to sign a new consent, right, Allison?
Yeah, so just as a little clarification, and this question just got answered, we did start Wisdom 2.0 in June of 2023, and that opened, so that was 2 years ago. We opened it to women 30 to 39 in October of 2023, later that year. It's open to anyone who has never before been in the study, but then we are now inviting people who have been part of Wisdom 1.0. We'll invite them to be part of the continuing cohort of 2.0. If you're in that cohort and you haven't been invited yet, you will be. We've had to spread out those invitations over time because our recruitment has been so high. We have to make sure we can get everyone the genetic tests and the risk assessment in a timely way. Good problem to have, but there's lots of interest of people both enrolling for the first time and then re-enrolling. So if you are in Wisdom 1.0 and you've been in the study for several years, you will soon be invited to participate and continue your participation in Wisdom 2.0. And as part of that, you do have to sign an updated consent form because there's a couple new processes, as well as do another color test, because the new test will give us the 10 million SNPs that Laura was talking about, and
Plus two
also
more genes, plus two more genes.
plus two more breast cancer related genes. It also now includes some other hereditary cancer genes as well. We're mostly focused on the breast cancer ones, but it will give you results from some other hereditary cancers as well. Yeah, let's see. There's also a question about West African women have been showing breast cancer in their early 20s. Is there a goal to lower our enrollment age even lower than 30?
Not just this moment, because again, it's like we want to be able to catch the people at 30 and see where they are. As we get better at finding or discovering that gene mutation, where we have a PRS for predicting cancers, the high risk of hormone negative, triple negative cancers, in African American and African women that Fumi Olopade has pioneered. So we should have that. We're going to implement that hopefully in the next couple of months. So as we, the data is that, so our data is that, even in Africa, it's actually much more common in women in their 30s. I mean, even, white and Black women can get breast cancer in their 20s, but it's fairly rare. It's more common in the early 30s in Africa. I think 30 is a reasonable place to look. As our data continue to mature, it is possible in several years that it might be something that you test at 25. There are, I think it'll be very interesting to see how the field evolves, where people might say, okay, that you get your, that you're going to get your, you come in for maintaining your health, that maybe you'll want to look at your polygenic risk score to sort of understand what's my risk of heart disease, what's my risk of, breast cancer, what's my risk of colon cancer, that these tests may be something that are broader than just breast cancer. Even so, another really important thing that's different that we forgot to highlight is that the genes, we're looking actually at a panel of 30 genes. And these genes include the high-risk genes for ovarian cancer, colon cancer, and breast cancer. And then some of the gene mutations can be ones that can be cancers of all kinds. So we're looking at that broader panel because as long as you're getting it, it's reasonable to do. And actually Color, our partner who's doing the genetic testing, is providing some of the genetic counseling.
Going back real quick to the PRS that predicts hormone positive disease, just to clarify that, the model that we've been using so far in Wisdom seems to be better at predicting hormone positive disease, correct? And that would be then encouraging women to take baby tamoxifen or risk reducing medications. Is that accurate to say? And then future versions of the polygenic risk score will start to predict for hormone negative breast cancers or other subtype specific breast cancers. But the ones to date have all been or have been the hormone receptor positive prediction. Is that accurate to say?
Yes.
Okay.
The most common one predicts for hormone positive breast cancer, but we have a need to be able to find, the people at very high risk for hormone negative breast cancer, which is more common in younger women. It's 2 or 3 times more common in younger women and more common in African American women. So that's, and someone asks how you can join, just go to wisdomstudy.org and follow the prompts. Join the study, join the movement.
There was another question about increasing enrollment in Black and Brown communities, and is this something we still need? And also, why is it important?
Well, I think that in past studies, especially the big studies that look at breast cancer risk, they have largely not included women of African ancestry. And that I think we can leave whole populations and communities behind if we don't study it. And, there are, I think it's really important because triple negative breast cancer is more common in Black women, and anybody can get any cancer at any time, right? So regardless of your ethnicity, your race, your age, but certain cancers are a little bit more common in different populations, and so you learn actually more about those cancers, how to treat them, and everything you learn applies to everybody, whoever they might be. So it's actually in everybody's interests that we learn, how to find it, how to treat it better, how to do things, because anybody can get them. But you want to get people in the study where these diseases are more common so you can learn more about them and learn in particular how to manage and prevent these cancers more readily. I see there's lots of questions that
I think you're good. I'm monitoring. Yeah.
okay.
Yeah. Yeah.
Someone asked about the ATM gene.
Mm.
Yeah, so ATM gene is considered a more moderate penetrant gene. But, we do screen, I mean, that is someone it's important to note that you want to be screened more frequently. I think, in the next year, as we add in the mammographic AI, that may be particularly important, especially if she's young, that might be an opportunity for her. So, and we're trying to also understand whether the polygenic risk score is something that can be used to modify the information we have about your genetic testing. So that's one of the reasons why we want these large studies to be able to ask these questions.
And then going back, Laura, you hit upon this, but it is a question we get a lot, which is I've been told I have dense breasts. What screening modality is best for me? And I think to start off, I think we have to to disentangle that there are two categories of breast density that someone would be told they have dense breasts. And it's really that highest density category that we're most sort of watchful of. Is that correct?
So what you get on your mammogram is there are 4 categories, A, B, C, D. A is mostly fatty. 2 is scattered fibroglandular densities, that's B. C is, they use the word heterogeneously dense or moderately dense, and then D is very dense or,
Extremely dense.
extremely dense or homogeneously dense are the terms that can be used. So about 10 to 15% of women have type D. Another 30 to 35% of women have type C. And of course, this changes by age. So it's not that useful to say, oh, having dense breast tissue is a risk factor when over half the population has it. Because it's not necessarily what we've learned from the mammographic, using artificial intelligence to really look at fibroglandular patterns, that we really can find probably the 10% of people who are truly at risk. Now, you've got 2 problems with extremely dense breast tissue. One is that there may be an underlying risk factor, plus it's going to be harder to detect. So some of that is, some of the tools actually help us find people at younger ages. I mean, or it'll help us find that group of people who might have that risk, and that 1 to 2 year risk is elevated because maybe the AI is able to find the cancers that really are masked. That's probably part of it, but there is also the part that's identifying patterns of fibroglandular tissue that are putting you particularly at risk. So I have been always anxious about these recommendations to tell people about their dense breast tissue because, somehow that translates into, oh, let me go out. Then people want to go out and get thermograms and ultrasounds and all kinds of things that actually are expensive and don't help them and can increase their chance of having a biopsy and don't really improve the yield. Fiona Gilbert in the UK at Cambridge, they just published a big study looking at, the contrast-based studies like MRI you have to have an IV and you're getting gadolinium to see if the blood vessels take up the contrast and wash it out, that's this kind of the hallmark that you might have a cancer. But you can do that with mammograms too. You can get an IV agent that's iodine, the same thing they use for a CT scan, and look to see if something's taken up and washed out. That's another way. And it turns out that MRI and contrast enhanced mammography do just about as well at finding these smaller cancers in people with very dense breast tissue. And they did this in people who had very dense breast tissue, type D. And also, what I think was important is that the yield of cancers was 4-fold higher than it was with automated ultrasound. Now, one of the problems, of course, is when you do MRI and contrast enhanced mammography, you're going to have more chance of a false positive. That just goes with the territory. Hopefully, over time, we're going to make that better. The idea of thermography, everybody comes up with this. It's such a cool idea, and it seems like it should work, but it really doesn't. And it's just too bad. And all it will do is, it's not covered by insurance. People will tell you it's better. You'll spend a bunch of money and it will not help you. There's a 50-50 chance of you're having a cancer if you had an abnormal thermogram, and 50-50 chance that you wouldn't if you didn't. So it's really, and my sister, who's a radiologist, was one of the investigators in that study, and it just doesn't work. There's big studies like in the 90s, and they didn't work, and then they upgraded the technology, did a big study in like 2010 to 2015. It just doesn't work. It's just too bad. There are increasingly going to be shorter MRs or fast MR. I think that's good. It'd be much more pleasant for people to be in the scanner for 5 minutes than it is for 40 minutes. And that's coming soon. That's all coming soon.
There have been other technologies you didn't mention, BEXA. You did mention thermography, but there's all these other things coming out, handheld things. And, I think we
I
get
mean,
these
there's lots
questions
of
all the
things you can
time.
do, but they don't work. And you can do them. Or like people say, oh, I want to have the thing where I can look for it every day. I don't think you want to know that. And I haven't seen any data from any of those studies that is promising.
Yeah.
Yeah.
And I
I
think
mean,
too,
ultrasound is a fabulous tool if you've got an abnormality to find it and do biopsies and help characterize things, but it is not a good screening tool. It just isn't, and it has never been, even though people think it is and use it all the time. It has a high false positive rate too.
one other question that's not on here, but what is the difference between a screening mammogram and a diagnostic mammogram?
Excellent question. So screening means you're coming in, you don't have a symptom, you're just looking to see if you might have something. A diagnostic is something that you do because you do have a finding. You have a mass, you had an abnormal screening mammogram or an abnormal MRI, and you're looking to try and find and look specifically in those areas where the abnormality is. So they'll do extra views, they'll do what they call compression views, and they'll look more carefully. They'll use an ultrasound to see if they can find a mass, or so they can guide a biopsy. That's the difference. So if you feel a mass, you're going to get a diagnostic workup, not a screening workup.
Mhm. And then another question just came in about lobular breast cancer, and maybe just describe what it is and what screening modalities work best.
So lobular is the second most common type of breast cancer. It maybe makes up 20%, 10 to 15 to 20% of breast cancers. Lobular cancers, instead of forming a mass early on, they kind of grow in like single file strands, and they don't really form a mass or something you can feel until they're bigger. And lobular is just like ductal, which come from the milk ducts, and the lobules are the machinery that makes the milk, and the ducts are the things that are the roads that take it to the nipple, and these are the cells that line those parts of the breast. But compared to the ductal, it's, often you're more likely to find these cancers late. Sort of a classic finding is flattening of the nipple, or like the breast shape has just changed. It's like 50% of women still find their own breast cancers. It's very important. You don't have to make it be, a half an hour exam in 2 minutes, like, see if you just, just take your hand up and down, 30 seconds in the shower, 10 seconds in the shower. Is there something new? You know what your breasts feel like. Is there a difference? Be aware of your body. Look in the mirror, put your hands up and put your arms back. Is there flattening out of the nipple? Are there things like that that just clearly look different to you? Someone who comes in with that kind of history, I always pay attention to. If there's really a suspicion for that, probably an MRI is going to be the most likely to find it. And sometimes, if we're looking for it, we can find it. It can come up as we call something architectural distortion, like there's something that's pulling in the tissue in weird ways. It often gets into the tissue behind the nipple and flattens out the nipple, but then it can also cause what we would call just a distortion in the shape of the breast. That's a clue. And, it's if we can find things that put people more at risk for lobular cancer, that can be helpful. Those are things that we're interested in. Maybe the PRS scores will be helpful for that. And there's a group of people who are really working on that to try and figure out how to help. That's actually one of the places that we need to improve.
And then
What do you do
the,
after a false positive?
Mhm.
Try not to panic and be upset. It's, I think that it can be very disturbing and very uncomfortable, but if it's, I think the key here is the false positive. If they found something and someone does a biopsy, but the biopsy doesn't make sense, that there's no explanation. Like if you had a mass and someone says, oh, it's a radial scar or it's a scar. Okay, now you have an explanation for it. But if it just comes back as benign breast tissue and there's something that's really focal that maybe they didn't do, maybe they didn't find the area that was really abnormal. And, those are the cases where you really want to come back in 6 months and do one more follow-up and make sure nothing else is going on, or make sure that there isn't something else that's going on. If there's clearly an abnormal finding in your breast that's different and they didn't find anything, then maybe you need more of a workup. But if you have something that, like small little calcifications, they take them out, they see the calcifications, there's nothing there, don't worry about that. Then you don't have to do more screening. You can just go back to regular screening. And there's a pretty high false positive rate, so.
And then another question is, can you speak to treating high risk women to stop cancer from growing in the first place? I think is what that's mentioning. So preventive medications, risk reducing medications.
Yeah, so it's something that's a really strong interest to me and to a whole group of people that have started this new meeting called Rise Up for Breast Cancer. So we're trying to revolutionize investigations to step up prevention for breast cancer. So we want to try and not only work on primary prevention, but secondary prevention. There may be opportunities, throughout a woman's lifetime where she's already getting recommendations to take hormonal agents to really try and incorporate breast cancer prevention into this, right? So for example, can we do that for birth control? Wouldn't that be amazing if we had things that actually, controlled, kept you from getting pregnant, but also reduce your risk of getting breast cancer? What about the people who have fibroids, especially fibroids when they're young, or bad fibroids? Is there a connection there? Black women have like twice the rate of fibroids as white women. If they're particularly bad, is that a link to higher risks for breast cancer and higher breast cancer mortality in Black women? We don't know the answer to that, but these are some things that that we've identified that might be a really important clue. Another thing is that we know that anti-progestins can control fibroids, but we know anti-progestins also reduce breast density, and breast density is a risk factor for getting breast cancer. So there may be some really cool, what I call secondary prevention opportunities, where we could use a treatment for fibroids that might also serve as something that would reduce the risk for primary breast cancer. Postmenopausal hormone replacement, if you're at high risk, there is a medicine called Duave, which is a little bit of Premarin, which comes from pregnant mares, horses, urine. That's really where Premarin comes from, the name. But they combine it with something called beta-doxyphene, which is like sort of a super duper tamoxifen type drug. It's extremely well tolerated. It's used for osteoporosis and symptom management and postmenopausal women. But it could be also something that works in younger women. So it's coming off patent in a year or so. Could we figure out how to make it cheaper and have it more broadly available? These are some of the ideas that came out of it. So I think we know that diet and exercise are for sure important. If you are thinner and you exercise more, you're going to have your periods later. Early onset of getting your periods carries a risk factor, a risk for getting breast cancer. So there are things, to get your kids to exercise more is a good thing. Making sure that you exercise more is good. We know this is good. Almost all the things that are good to improve your health overall are good to reduce your risk of breast cancer. There was recently a study from Canada that showed that regular exercise with a physical trainer actually, reduced the risk of dying of colorectal cancer, metastatic colorectal cancer, which is really amazing. If exercise was a drug, I mean, every drug company would be rushing to develop it. But because it's hard to get in, so these are the things though that we know that would that work and work well. I think that we know that this really small dose of tamoxifen, baby tam that we call it, relative to 20 milligrams, which is the standard dose, just the baby dose, 5 milligrams is really very well tolerated. There are a few people who still just can't take it and don't like it, but this lower dose is very extremely tolerable and seems to do just as good a job at reducing risk. And so who are the people who ought to be thinking about doing that for 2 or 3 years? Well, that's the people who might have high density, might have a high PRS for the 313 genes. And, what we want to do is have tools to say, like, are you benefiting? If you're taking an anti-cholesterol drug, you see your cholesterol go down. If you're taking an anti-hypertension drug, your blood pressure comes down. So, can we use imaging as a way to say, oh yeah, I'm definitely benefiting, and those risk factors like breast density are going away, or the background enhancement on an MRI, stuff that makes it look white, if that's going down, then you know that you're benefiting. So I think those are some of the critical things that we need to do to advance or the field of prevention.
And Laura, similarly, so you've talked about fibroids, but are there any links between endometriosis and adenomyosis and breast cancer risk?
Well, so that's just recently come up. So again, Duave, this medicine Duave actually is well treated. I mean, that really treats and uliprisone acetate, which is the antiprogestin. Both of them control endometriosis. So it is, I think that there's more to these stories and more connection to these things. And that's why I think some of these other conditions may be opportunities where if you may not want to take something, but if you're suffering from something else and you can get relief, how can we make the things that we're doing, for weaning from breastfeeding, or weaning from, endometriosis or fibroids or things like that, where you want to take something anyway, that there's where the synergy could be. I think these are opportunities to be really thoughtful about how to bring our breast cancer rates way down. I hope so. I mean, that's the path that we're on. Trying
And
to check
just
that
to
box,
say one more time the name of the medication that treats fibroids and also reduces breast density.
So Duave is one of them.
Mhm.
Elapristal acetate isn't available in the US, and because it was associated with some liver toxicity. So uh, we're working on trying to figure out how to get rid of the part of the drug that causes toxicity and get it back on the market. It's tricky sometimes to test these. It's interesting that the antiprogestins, which are like mifepristone, for example, is an antiprogestin. And, I think all of the political nonsense that's around interfering with women's access to reproductive um, choice gets in the way of being able to use some of these medicines that could be very effective. Um, so we want to be very mindful of making sure that those don't get taken away for any number of reasons. So it's part of what we're working on with Rise Up.
And just one more question on the risk-reducing medications. Any evidence to continue baby TAM beyond 3 years for people with family history and CHEK2 mutations?
Well, the standard trials that were originally done were done for 5 years. Um, Andrea DeCenzi, who came up with the whole baby TAM idea, did it for 3 years and seemed to work, and the 10-year data suggests that it continues to improve. I mean, I think, I don't think we know because we haven't tested it head to head. And I think I would probably want to look and see, well, but some other factors. How dense is the breast tissue? Has that gotten better? Has the background enhancement on MRI gotten better? And, that's one of the things that Jennifer Rosenbluth and I are looking at. What happens to people who have that background enhancement on an MRI and you stop their medicine like the TAM and boom, it all comes back. We've sort of noticed that in our GCIS active surveillance study. And what can happen is, you know, for some people, you stop it and it just stays down, and others, it comes back up. So we've actually started a study to try and look at that and try and look. She can actually has the ability to grow tissue, little bits that take from fragments of tissue, can try and grow it in what we call organoid cultures, so that we can try and understand what's behind it. And that background enhancement has something to do with estrogen metabolism. So I would probably look at some of these other secondary features to try and figure out, um, you know, whether or not continuing on with it will help you. It's a low dose, and with this low dose, it's not very risky. But it is very interesting that, like a lot of these drugs were, when you're developing drugs, the incentive is to use as high a dose as possible, because if you're going to spend a bunch of money, you don't want to use too low a dose and miss seeing an effect because you tried too low a dose. So people tend to want to, use higher doses of medicine. But it turns out that, like, especially for the aromatase inhibitors that cause a lot of symptoms, and tamoxifen cause a lot of symptoms, that not for everybody, but for some people, that the lower doses work just as well. So, it's opportunity, I think, for us to be thinking better. People can't tolerate the medicines, they're not going to take them, so they can't get the preventive benefit. So you got to work on, I refuse to give in and accept that, that things are too, that they have to be toxic to be effective. I don't subscribe to that. I think we just haven't used our imagination properly. We haven't tried enough other things.
So speaking of trying other things, there's a question about vaccines, and do you see risk assessments or risk-based assessments being paired up with vaccine trials and using them in combination?
Um, I don't know. I was just reviewing a vaccine last Friday. and this may be something that's better to be used as in a therapeutic sense, but I think people are trying to think about how can you potentiate the immune system so that you have better surveillance to do things. I think the opposite of that, unfortunately, is autoimmune disease. Right? So there's the yin and the yang, all these things, you toy with one thing, something else goes off here. I think that I think one of the problems that we've had is trying to figure this out, the new drugs, Keytruda and all the PD-1 and PD-L1 inhibitors. I think the immune side effects are higher than we've realized, and they can persist, and we haven't figured out a way to find them early. Maybe we're using them at too high a dose and for too long a time. You know, I would want to know that you're not going to be causing autoimmune disease. Because once you've vaccinated someone in that way, there's no turning it off. If you're giving it, you can take it away. But if you turn the body on, I think we have to develop vaccines that have the ability to turn things on and turn things off. It's challenging. And there isn't something in breast cancer, because it looks more like breast tissue, right? If you had a target, it would work, like a HER2 positive vaccine. 30 years ago, I was working on a HER2 vaccine till I discovered two things. One is that the embryo expresses HER2 almost in every cell. So in some ways, HER2 is kind of a throwback to when the cells are dividing and multiplying, so that it's like, I think from a scientific standpoint, the body in development knows how to turn things on so everything grows, but they also know how to turn it off. And these are some of the things that can turn on. And so you have to be careful. Then you wouldn't be able to give it to anyone who's ever planning to get pregnant. And now we have such good treatments for HER2 cancer. I'm not sure that we need it. So it's tricky. I think it's really tricky. And, IDO, there's another molecule, but, when you get pregnant, one of the things that you can do is one of the things your body has to do is make sure that you don't reject the baby, because the baby is not self. The baby is half you and half somebody else. And so the body's already figured out how to cause that, that there's a molecule called GDF15 that actually is one of the things that causes this lower immunity, that therapeutically you can have an antibody that's neutralizing to that might be great as a therapeutic, but it's a hard problem. It's a hard problem. It's not like you're going after a bacteria or you're going after a virus or it's after self. So it's tricky. I love immunology and I'm super interested, but tricky.
Yeah.
I'm hopeful always.
Other
Oh, you're going to get me on the multi-gene early
I know it's not a
before I
quick
shit
topic, but
myself.
this
Okay.
is one of the things we want to do is tee up some topics for future community forums. This is one that we've been getting a lot of questions about as well. So
Oh yeah.
just quick
Everybody,
comments on
yeah,
these
everybody
NSAID
says they
tests
want
and
to get
liquid
the
biopsies.
multi-cancer early detection test. Oh, what's the harm? Let's just get the test. I want to get the test. But if you look at Grail and all these tests, they don't find things early, which is good, but they find things late. Okay, I'm pretty good at finding things late too, so I don't know how much value they have, but they're like $1,000. It's like if you screen using the American College of Radiology guidelines with a $300 test, it's $30 billion to screen everyone in the population. If you added $1,000 test, it would be like 70 billion. Or 80 billion. Now we're for one test for 1 year. Now we're getting into the defense budget territory. It's like, we have to be thoughtful about this. And, there's harm to finding things. So you get this multi-gene detection test. It might tell you, oh, it's your pancreas, or oh, it's something else. Now you're just waiting for the other shoe to drop. So I think early detection is much more complicated than people think. They think, oh, let's just find it early. That's good. Like, okay, well, someone will say to me, oh, I can find cancer when it's one cell. I'm like, okay, please don't, because the body could usually fight that off. I mean, why do people get big DCIS and it doesn't become invasive cancer? Because your body is actually working all the time. We screen twice as much as they do in the UK and other countries, and we have twice the detection of DCIS. But they don't have higher cancer death rates and things like that. So there are harms from screening. There are harms from finding these early things. If they could get this down to something that was like $100 and it was really did find things early that other things wouldn't find, I would be all for it. But this is looking for what we call methylation, or certain changes in the DNA that's circulating around in your blood. That's very different from genetic testing to see if you're in your germline, in your inherited genes, you have an error in DNA repair, or something that predisposes you to cancer. So those are, and there are some early detection blood tests, but there aren't any that really work. But people are trying. Well, PSA, for example, is a test that does work for prostate cancer, but actually they did it wrong. 4 is not the right level. Actually, there's a lot of data that if you could do one test and you have PSA below 1, you will never get prostate cancer. You should never be screened again. But it turns out that there's a whole bunch of people with between 1 and 4 who do get lethal prostate cancer. So it's not like, it's again, these things are complicated, and then you have to do these long-term follow-up studies to follow people and keep looking. I think that's why a study like Wisdom is so important, because you can continue to follow people and you can continue to learn and ask questions. What are we doing right? And what are we doing wrong? And how can we make it better? There has to be, I mean, if you're spending, 15 to $20 billion a year, don't you think you ought to have something that helps you say, gee, how good a job are you doing? And where is it working and where is it not working? Shouldn't we be spending just a little bit on trying to find out if we're doing it right? If you think about the most innovative companies in the world, they spend 10 to 20% of their annual spend or their annual revenue on research and development. We should be doing the same. That's what we're trying to do with Wisdom.
And there is a good link in the chat that Diane added on multi-cancer early detection tests. Laura, you just mentioned DCIS, and there's one more question in the chat about DCIS, and let me just make sure. Please address DCIS and the new way of treating some.
Okay, so DCIS, ductal carcinoma in situ. What happens is you have cells that look like cancer, but they're confined to the duct. DCIS by itself is not life-threatening. It poses no particular threat. But it is a risk factor for sure for developing invasive breast cancer. So how do you know who's going to develop something, or who, our standard approach has been to operate on all these people. That's been the standard of care. But if you do that, you never really can ask the question, well, can you make it go away with just some kind of hormone risk-reducing agent? Well, it turns out actually you can. We started a registry like 20 years ago for people who really said, wow, I don't want to have surgery and I don't think there's any good data to support my doing it. We're like, okay, well, we'll follow you every 3 months with an MRI and we'll see what happens. And we actually learned how to use MRI as a way to find out who is at higher risk for developing invasive cancer and who, like with time and endocrine therapy, like tamoxifen or low dose of endoxifen or so on, that you could do just fine and you had as low a risk of getting cancer as someone who had had surgery and radiation for DCIS. So, and there are now some studies, the COMET study also showed that if you are randomized to starting with surgery or with just watch and wait, that your chance of getting invasive cancer really isn't any higher. And you can find it in time to intercede. So, and there's a couple of other big international trials. So I think the pendulum's starting to swing. We have a big study called Recast DCIS. It's called Reevaluating Conditions for Active Surveillance Suitable as Treatment. And what we do is, instead of saying that everybody should start with surgery, we're saying, you know what? There is no harm. We know that from the COMET study. We know it from our study on active surveillance, that DCIS isn't an emergency. You have time to look through your options. So you can start with 6 months of endocrine therapy. We do that for people with stage 3 disease. So for goodness sakes, you could do it for someone who doesn't have invasive cancer. So we have the standard of care versus 3 other different medicines that we can randomize people to. And they can get one of these 4 medicines, and we follow carefully with MRI. We look at 3 months and 6 months, and at 6 months, we make a decision. Are you somebody who's highly likely to succeed with just active surveillance? Or does it look like you've got the kind of, the MRI suggests you're going to be someone who's maybe a 50 or 60% chance of getting invasive cancer, and that is more, there's a surgical area that should be removed. I think it's a great way to think about it. There's no harm. And there are now 19 sites around the country that have that open, and hopefully more soon. You can go to the Recast website to, it's just Recast DCIS. And you can look to see where those sites are. But I think that's going to be one of the keys for us for developing new preventive interventions, is studying it in high-risk women. I personally think about DCIS as just being an opportunity for prevention and to learn how to do it better.
Excellent. Well, we are just over time, so want to say a big thank you to everyone for joining
Last
us.
question on your last slide, which was, what is a liquid biopsy? That means you're just looking in the blood for little bits of circulating DNA or changed proteins that could indicate the presence of cancer. That's what a liquid biopsy is.
So we do have an evaluation that's in the chat. We'd love to hear from you if any of these topics would be ones you'd like a full forum on. I know we're already planning on some of these topics, and we could spend probably multiple forums on each one. But just wanted to say thank you so much to everyone for joining us. Thank you, Laura, for being our expert and recipient of all of our questions.
Stacy, thank you for your emoji here. I love that.
So we will, and one of the questions Stacy asked was about, will Wisdom be presenting at any conferences soon? We will be heads down looking through all the data next week, and we'll be planning to submit some abstracts to the some upcoming conferences, and so we'll hopefully be presenting soon.
Hopefully writing it up too. We have lots
Yes.
of papers to write up and get out. So
yes, and so our next forum is on July 28th. In that forum, we'll be going through the newest iteration of our risk assessment and model in a little more detail. So around our breast cancer surveillance consortium version 3, how it differs from version 2, as well as some of the updated polygenic risk scores that Laura mentioned earlier today, and what our plan is for implementing those.
Yeah, and I hope this is helpful. And the thing too is, if this is helpful for every 4 months, just to have questions, you can be sending questions in, and we can do this because we really want to make this more interactive and more able to address some of the questions you have. One of the things that I think is going to be really fun, that hopefully maybe towards the end of the year, although we probably can't invite Suzette on unless she's here in the States, but people should try and come to Rise Up, which is February 19th to the 21st in February. And we have, for advocates and patients, we're having extremely low rate. There's a sister study to Wisdom in Europe called MyPABS, My Personalized Breast Cancer Screening. And it's just so, the differences in the baseline characteristics are so different. The rates of people who have had biopsies is less, the amount of DCIS is less, the amount of hormone replacement use is way less in Europe than it is here. I think people have sort of decided that the Women's Health Initiative never happened, and really that combined estrogen progesterone doesn't cause breast cancer, or it doesn't increase your risk for breast cancer. It does. It's just if your risk is super low, it may not matter, but there are better things like Duvet that you can use. So lots of opportunity, you know.
Yep.
Thanks, Stacy.
Yes, thank you everyone for your excellent questions. As Laura mentioned, feel free to send those at any time and we'll keep a running list. And I think it is a great idea to do these more frequently and we can get your questions answered. And your registration for today is your registration for every future forum. So we'll be sending reminders and things like that. So be on the lookout for what the next topics are and get those questions ready and we can make sure that they get asked in those specific meetings too. So with that, thank you so much, everyone. Have a wonderful evening and we'll see you next month.
Great. Thanks so much.
Thank you.
Bye.
Bye.